morning. This is Katie Diamond-Falk. I'm the MedPeds Program Director, and I'm going to get us started today. So it is my pleasure to welcome you to Grand Rounds with Jessie Schaumberg, one of our fourth-year MedPeds residents. Her topic today is going to be schistosomiasis, a neglected tropical disease in Maine. And a little background on Jessie. As any good MedPeds person, she had broad interest from the beginning in college when she was at University of Miami. She majored in microbiology and immunology and then minored in Spanish, chemistry, ecosystem science, and policy. So she went on from there and went to Toro University College of Osteopathic Medicine in California before coming out here to join us. Since Jessie's been here, she's been very productive. She helped us to get started on our Global Health Club. She's been a co-chair for the New Mainers Initiative, which is a women's immigrant yoga project here. She has helped with an education innovation grant that we're working on, an immigrant health educational initiative here. Jessie's also managed to spend in time to do some work in the Galapagos during her residency and continues to follow her passion in immigrant and refugee health. Jessie has done research related to the use of the addiction medicine team when treating our patients with endocarditis and substance use disorder, and is working on publication in that as well as several other projects. So join me in welcoming Jessie to do her presentation today. Thank you.
Okay, thank you for the introduction, Katie. So again, my name is Jessie Schaumberg, fourth year MedPeds resident, and I'm very happy to be doing my grand rounds this morning on schistosomiasis, which is a neglected tropical disease that you may see here in Maine. So I have no financial disclosures, obviously. And let's go through our objectives. So I'd like us to focus on understanding what pre-departure chemotherapy is and the management and epidemiology of NTDs. I want us to understand who and when to test for schistosomiasis and to recognize symptoms of early and late schistosomiasis infection. But in order to talk about schistosomiasis, I think it's really important to talk a little bit about history, about global migration and the refugee crisis, and about neglected tropical disease management as a whole to really fully understand why we're even talking about this today. So why schistosomiasis? Why are we talking about this? And for me, my interest is personal. So this is a picture of my grandfather, John Statura, at age 6 in Iran. He was actually originally from Poland, and when the Nazis and Soviet Union invaded Poland during World War II, his family became refugees. They initially went to Siberia, then to Iran, to Pakistan, India. They spent 3 weeks on a boat going to Rhodesia, which is no longer a country, and then to Tanzania, where he's pictured here at age 10, again with his mom and brother. And then now, this is him last year visiting Tanzania for the first time since he was a refugee there in the country that really welcomed him with someone from the Maasai culture. And this really is what has always interested me personally in refugee health, is hearing his stories. So the last picture is a picture that I took when I was able to go to Tanzania as a medical student and to help out with some schistosomiasis research and learn a lot from the local doctors. But why are we talking about this here today? And really, his immigrant journey that began during World War II is not that different to what we're seeing here now in Portland. The refugee process may have changed a bit, but we're still seeing a lot of immigrants arriving here in Portland. So about 1 in 21 of your population or of your patients is likely to be an immigrant. And the immigrant population is increasing faster than the general metro population. So it's really important to understand how to take care of this population. Additionally, when you look at the percentages here on this bottom graph, you'll see that although most people are coming from Canada, increasingly a larger amount of our patients are actually coming from Eastern Africa. And they make up a huge portion of our GDP, of our workforce, of our communities. So As being advocates for our community, we have to learn how to take care of things like schistosomiasis. So let's go through a case. We have an 11-year-old female with persistent gross hematuria. And spoiler alert, it's going to be schistosomiasis, but let's go through it anyways to make it more fun. So we have our 11-year-old female with persistent gross hematuria. She has been having bloody urine, since she was 7 years old with all of her voids. She has also reported occasional blood spotting in her underwear. She reported that she had dysuria years ago, but this now resolved, and no other symptoms, no swelling, fevers, no oliguria. As far as her history, she had actually been to Brazil previously, and she was hospitalized first for abdominal bread-related pain. They thought she ate too much bread, and I couldn't resist putting in a picture of a failure to bake bread. I imagine this is somebody who's like nailed it during COVID, because did you even live through this pandemic if you didn't try to do a stupid hobby like bake bread? She also was hospitalized once for a respiratory illness, and she underwent quite a workup actually for this hematuria in Brazil. So she had a cystoscopy and a renal biopsy, neither of which were fruitful. Family history: her brother had a history of dysuria, not currently. And social history is what I really want to focus here. So she was born in the DRC, she moved to Goma at age 2, then went through Brazil, Latin America, and the United States. And I want to take a minute to go through a little bit of the history of immigration from Congo to the United States, because I think as pediatricians, we're taught to be advocates. So it's good to get an understanding of why we're seeing this big influx in our population. Why was our basketball stadium full of brand new arrivals to Portland last year? So I'm going to go through this video, bear with me. So our patient's journey started here in the Democratic Republic of Congo, but historically the rise of the Congo Empire dates back to the 1200s, centered in modern Angola and Congo. In the 16th and 17th centuries, with the rise of European influence and trade, British, Dutch, Portuguese merchants began to engage in slave trade throughout the Congo intermediaries. And while the Congo Empire was initially in control, whoops, sorry about that. Wouldn't be grand rounds without a technical error. There we go. And so while the Congo Empire was initially in control, as the slave trade spun out of control, so did their grip on the region. This really culminated in the 1870s when King Leopold of Belgium colonized Congo and Rwanda. King Leopold's reign was extremely violent. He exploited Congo's people and resources. And under his reign, false ethnic identities were created to maintain a power structure. Here you see Belgian pseudoscientists measuring the facial characteristics and skin color in order to divide local Congolese people into 2 ethnic categories, Hutus and Tutsis. Darker-skinned individuals were assigned ethnic identity cards as Hutus, about 85% of the population, and they were deemed the ideal body type for farming, not profitable. Light-skinned, taller people were designated as Tutsis and allowed to attend livestock, a more profitable industry that led to higher power positions in the region. This division of power through creation of false ethnicities created socioeconomic divisions and later led to war and conflict within the region. And when you think about the fact that scientists were really doing this, I think it really resonated with me today, because there's so much mistrust in science that can be really frustrating during a pandemic. But I think we also have to understand that historically, there's been a lot of untrustworthy action. So moving forward, in 1960, the Congolese people gained their independence from Belgium. However, there was turmoil and chaos throughout the political handover. So pictured next is the first prime minister, Patrice Lumbumba, who was murdered shortly after his election, reportedly with US and Belgian complicity. In 1965, in the vacuum created by Belgium's withdrawal and Lumbumba's assassination, this man, Army Chief Mobutu, was able to seize power and renamed the country Zaire. He was the dictator of Zaire for 30 years, which was marked by extreme corruption and exploitation by Zaire's elites and Western countries. This really lasted until 1996, when the Rwandan genocide, fueled by 100 years of ethnic tensions between Hutus and Tutsis, spilled over into the Congo. And this period of 1996 to 98 is known as the First Congo War. During this time, Mobutu's dictatorship was finally overthrown by Laurent Kabila, who was previously pictured, and Zaire was renamed the Democratic Republic of Congo again. This was really immediately followed by the Great War of Africa. Here is shown thousands of burial sites, and that lasted from 1998 to 2003. At the start of this war, Kabila, the president, had severed ties with Rwanda and Uganda, whose armies quickly retaliated. 9 African countries and 25 armed groups were involved in the war, and 5.4 million people were killed in Congo's borders. 2 million people were displaced from their homes, and an estimated 400,000 women were raped, leading to the refugee crisis. And although the war ended in 2003, there are still after effects seen today and several active paramilitary groups in the region contributing to the refugee crisis. So you see here, our patient moved from a more violent area of Ituri to Goma, which is an area with one of the largest refugee camps in the country. So these are internally displaced persons in Goma in the DRC. But many people actually go to Uganda, Rwanda, Burundi, and Tanzania, where the majority of the refugees from the DRC live. Congolese refugees' arrivals in the US has kind of fluctuated over time, but you can see they're not just coming from the DRC, they're coming from other countries. And in the last few years, given the halt on refugee admissions to the US, things have really changed. So people aren't always refugees now. A lot of them are asylum seekers, and they fly to Brazil. Many of them live in favelas for a period of time, which can be extremely dangerous. And a lot of their journey is marked by interaction with drug lords, sex traffickers, and human traffickers. Through those routes, refugees manage to navigate to Peru, typically via a series of bus rides that are very dangerous, and with the help of their refugee community, often interacting through apps like WhatsApp and different text groups, so they can figure out where is a safe place to stay, where is the next place they'll go, which hostel is welcoming in Ecuador, which police they can pay off, and which ones will steal all of their money. From there, from Ecuador, they go to Colombia, and many people from Colombia take a boat to the very southernmost point of the Darien Peninsula. These boats have been known to capsize in the past. Here in the Darien Peninsula, this is really worth mentioning, because when I've talked to many of my patients about their journey, they all highlight Panama as being the most dangerous. And it's because of this trek through the national forest that takes 7 days long. There can often be flash flooding, animal attacks, and they always talk about the many bodies that are littered on the side of the forest. From there, most people wind up walking through Central America, from Costa Rica to Nicaragua, through Honduras, they walk. And they know where to stay, again, through these communities, through these WhatsApp groups. The crossing from Guatemala to Mexico is often across this river. It's called the Suchiate River. There's a great LA Times about it, and most people raft across. Although there are other ways to cross that are less dangerous than a raft, during the COVID pandemic, where immigration is not allowed, people often immigrate the most dangerous way. From there, usually in Mexico, people actually register and have 30 days to leave Mexico, and they have a choice. Do they go north across the US through a port of entry? Do they cross the river? Do they hike across Arizona? And really, I think a lot of that depends on experiences of family members, as well as how likely they think they are to be granted asylum. Someone from Central America who's less likely to be granted asylum may choose the most dangerous path to cross the river. Whereas someone who is from the DRC and thinks they may get asylum may choose to cross at a port of entry, or, for example, one of the many bridges into Texas. There, they can spend 8 months to a year in a detention facility, and then are often released with or without an ankle monitor and then sent on a bus to their next destination. So in our case, Portland, Maine. Now, I realize making this video is a very, very oversimplified explanation of what our patients go through, but I think it's worth knowing a little bit about and trying to learn more to be better advocates for our patients, because a lot of their health is really determined by these factors in this journey. So let's get back to our patient, hematuria. We're back. And I'd like to go through their physical exam, which was unremarkable, and their labs. So our patient had 14% eosinophils and an absolute eosinophil count of 1220, so elevated. And their UA was remarkable for 3+ heme, 2+ protein, and 50 to 100 red blood cells. They had a normal UPC ratio, CMP, and their renal ultrasound was unremarkable at their initial workup. So let's kind of reframe now. We have this 11-year-old Congolese female immigrant to Maine with chronic gross hematuria since age 2, with proteinuria and peripheral eosinophilia. So where do we go next from here? And I'd like to offer this article's great approach to renal pathology in a patient from a LMIC, or low middle income country. So first, I'd like to highlight non-communicable diseases, aka common things that you would normally think of in your patient from Maine. When you're seeing a patient from abroad, I want you to first always think of common things you're going to see here, because that's probably still what it is. Nephritic, nephrotic, diabetic, whatever it may be, those things are still probably going to be the most common, and many of our patients have lived here for years. The next category over here on the right is I want you to think about occupational and environmental exposures, because the hazards that people are exposed to abroad are much different than in the US. For example, Bosnian immigrants are much more likely to have aristolochic acid as a toxin to their kidneys that have caused kidney failure, whereas a 17-year-old former sugarcane worker from Central America may be predisposed to Mesoamerican nephropathy because of his very high exertional work. You want to ask about heavy metals. If you're thinking about a patient from Bangladesh where arsenic is in their water supply, you want to know that and think about that as being a possible etiology. And then last but not least, in the middle, we get to our communicable diseases. So these are all the weird infections that you're throwing out there on your morning report idea. But it's often, this list can be so overwhelming, you don't know where to start. Should you start with onchocerciasis or leptospirosis or dengue? Where do you really start? And for that, I'd like to talk a little bit about neglected tropical diseases. So these are a group of preventable infectious diseases that affects more than 1 billion people globally. And they really have a high morbidity. They perpetuate poverty by really damaging the social system, the economic system in a country. So for example, something like elephantiasis is very disfiguring. It's socially disfiguring. That person is potentially out of work, a job, in a community for their life. And that really perpetuates the cycle of poverty in that community. Other common NTDs are trachoma, onchocerciasis, schisto, which is also called snail fever, and soil-transmitted helminths. Again, all preventable. So the next thing I'd like you to think about when you're working up a patient from another country is, what would the medical assessment be if they were a refugee? So for US-bound Congolese refugees, you can go to the CDC website and get this great idea of what they went through before they came here and were admitted as a refugee. First, they'll have an overseas medical exam 6 months before departure, and they'll be screened for inadmissible health-related conditions, so things like active tuberculosis. Then, 3 weeks before departure, they'll get another medical screening. And last, they have a fit to fly pre-embarkation check. So here, they'll get their temperature taken, make sure they don't have a fever, aka bring potentially malaria or Ebola to the United States, get screened for lice. And then they'll also have what we call presumptive treatment of intestinal parasites and malaria. So presumptive treatment is kind of what it sounds like. You're taking a patient from an area where a disease is endemic, generally a neglected tropical disease, And you're assuming that they have it because the prevalence is so high. And the decision is to treat all patients without testing in order to make sure when people arrive in the US that they are healthier. So, for example, for our patient from sub-Saharan Africa, had she gone through the refugee process, she would have been treated for schistosomiasis with praziquantel as long as she was over 4 years old. She would have been treated for strongyloides unless from a Loa endemic area, because that can cause ivermectin can cause encephalopathy in Loa patients. She'd be treated with albendazole for soil transmitted helminths, and then she'd also be treated for malaria. And to show a little bit about why we do this and how it works. So this is a study that was done in Minnesota that compared refugees upon arrival in Minnesota before and after presumptive therapy with albendazole was started. So albendazole is partially active against schistosomiasis, although not the definitive treatment, but this was kind of where we started. So if you look here, 5.6% of people who were not treated, so in the early period of this study before treatment was started, 5% of people had schistosomiasis. After pre-departure presumptive treatment with albendazole was started, only 1.8% of people on arrival to Minnesota had schistosomiasis. So that's a pretty substantial reduction in a disease that can cause lifelong morbidity. The next thing I'd like you to look at when you're working up a patient from abroad are the CDC's domestic refugee health screening guidelines. So this also applies to other immigrants besides refugees, but really it's a list of things that you should be looking for. So in addition to general labs, you would do broad STI testing, TB testing, a lead screen because lead toxicity is more common, a mental health screener because of invariably the reason they came here. And if no presumptive treatment, you should be testing for malaria, strongyloides, and schistosomiasis on their arrival. And even if they were treated, you could consider retesting. So let's regroup to our patients. So we have our female with gross hematuria, eosinophilia, proteinuria. And she has not received these things. She does not have pre-departure presumptive chemotherapy. She hasn't had a refugee health screening, so you should be testing her for schistosomiasis. And that's exactly what they did. So this is a concentrated urine microscopy. And if you look at this little guy here, this is a schistosoma hematobium egg. He's got this little terminal spine right here, is kind of wiggly tail hanging off. And that is indicative of this species of schistosomiasis. They also got a serum antibody that was positive as well. So our patient has this diagnosis. What does it mean? What do we know about it? So let's talk a little bit about schistosomiasis, which is also called bilharzia, or my favorite, snail fever. And going back historically, I'm kind of doing a lot of history, but I thought this was interesting. So going back to 1500 BC, mummies actually had schistosomiasis. You can see the eggs on dissection, and this is actually a hieroglyph of a bird urinating blood, and it was previously called bloody urine disease in ancient Egypt. So it's a disease of antiquity. Moving forward, this guy, Theodore Bilharz, with a great stash, in 1851, he discovered that the schistosome worms were actually two separate sexes. And I think that if all our textbooks were written like this, I'd probably be a better student. He says, this is not developed into a fairy tale, as I had assumed, but something more miraculous, a trematode with separate sexes. So I can imagine he really nerded out over this huge discovery. And then let's move forward to today. So schistosomiasis is now classified as an NTD. And if you remember, we said NTDs affect millions of people. Schistosomiasis is the second most devastating parasitic disease in the world. It has a very high morbidity, and it perpetuates poverty because it causes anemia. Here you see one of my friends in Tanzania donating whole blood, which was directly given to a patient. It can cause malnutrition, disability, it increases the prevalence of cancer, and it also decreases cognition and learning. So this study, a meta-analysis of kids with schistoinfection versus not in endemic areas, showed that children with the infection have decreased school attendance, scholastic achievement, learning, memory. But on the other hand, they have equal intelligence and equal reaction time. So there's follow-up studies to this that actually show that treating schistosomiasis can reverse some of these effects. So it's important to intervene early, and it's important for pediatricians to intervene early. Looking at the epidemiology, 240 million people have this infection around the world, and 700 million people are at risk throughout Asia, Africa, the Middle East, and South America, and some of the Caribbean islands. The prevalence in preschool age children is especially high. So looking here in Tanzania, where I went on my rotation, greater than 51% of kids have hematobium infection in the preschool age group. And not only do kids have the highest prevalence, so shown here on the red graph, you see this younger age group of 10 to 14-year-olds has the highest prevalence of schisto. But when you look at this blue line, this shows egg shedding in this particular community in Kenya. And you can see that the younger age groups also have a higher intensity of infection because they're shedding more eggs. So it really affects them twofold in that way. And this is mirrored for both Mansoni and hematobium. So I would not be able to do this lecture without doing a life cycle slide. I apologize. I'll try to go through it quickly. So our journey starts here with our eggs. So humans shed eggs in feces. So Mansoni and japonicum are mainly spread through fecal matter directly into fresh water or urine. So urinating near fresh water is where hematobium is found. And this is a hematobium egg here. So in the fresh water, these eggs hatch and they release muricidia, which I imagine kind of look like pygmy puffs swimming through the water here in Lake Tanzania. This is a picture I took. The eggs then, or the muricidia then penetrate snail tissue. So these are bolinum snails that I saw while I was there. And inside the snail, they burrow into their gut and sporocysts develop. So these are all little schistosporocysts here. From there, they develop into cercaria, and the snails release cercaria into the water. So this is their head here, their head here, and their tail here. And when an unbeknowing human goes into the water to bathe or do their laundry, or some tourist goes water rafting in the Nile, the cercaria then penetrate the skin. Through chemotaxis, they swim towards our skin. And this is about 5 minutes after the cercaria has penetrated the skin. It goes under the epidermis. 20 minutes later, the cercaria tail is lost. It becomes a schistosomule. So this kind of blob is called a schistosomule. So now he's going through the dermis and then finally entering a blood vessel. After this, they then migrate to the lungs, into the heart, where they mature into adults, into the schistosomule. And eventually they migrate to the portal venous system in the liver, or the venous plexus of the bladder, or the mesenteric venous plexus. And through this process, they turn into adults. So here we have our paired worm couple. So the male worm is pictured here, and he has what's called a gynecophoric canal. So he essentially folds in on himself. And then this is our female schistosome that is kind of laced into his gynecophoric canal. So the male and female worm, they fall in love, notebook style, and they build their homes together in our blood vessels of either, again, the mesentery, the portal venous system, or the bladder. And there they lay eggs, they have families, and hopefully don't live happily ever after because we learn how to diagnose it. So let's talk about what happens during an acute infection. So it's a Th2 response. Remember, when you have the helminths, you have a Th2 response. So you get your dendrites here that phagocytize an antigen, and this sets off your large Th2 response with interleukins and eosinophilia and this large inflammatory reaction that initially occurs. So days after the infection, you can have what's called a cercarial dermatitis. This picture is actually in Maine. So We do have schistosomiasis endemic here in Maine, although it's not the type that we're mostly talking about in this talk. It's not going to cause liver or bladder problems. But you do see cercarial dermatitis from a different species of schisto in Maine, and it looks pretty similar to the one that you would see in Africa as well. This picture is actually on Long Lake, and the normal definitive host for this schisto is the merganser duck. So fun fact, maybe you will see this, maybe even more often. But let's talk about acute schisto. So Katayama fever is what it's classically called. It was named because it was discovered in Japan, and it mostly occurs in people who are having this infection for the first time. So if you can imagine when the new husband was immigrating to the Katayama Valley in Japan, and all of these new arrivals kept getting fevers and symptoms, it became Katayama fever. So you get fevers, chills, myalgias, headaches, urticaria at times. You can have cough and respiratory symptoms. Here you see some pulmonary infiltrates, GI upset, eosinophilia, and hepatosplenomegaly. Next, I want to talk about chronic infection, which is what you're more likely to see. So remember we talked about the schistosomes shacking up together and making a life and laying their eggs in your venous system. So this is what causes the primary pathology of schistosomiasis. So here you see an egg in the middle, and our Th2 response is now evolved into causing a granuloma surrounding this egg. And the granulomas are really what cause the pathology and morbidity of schisto. So there's three types. I'm going to start by talking about hematobium, which our patient had. Again, we got the terminal spine here. This is a Biome filaria snail, the intermediate host, and its region is essentially sub-Saharan Africa in the Middle East. So hematobium lays its eggs in the urinary and genital tract. So the first symptom you want to think about is dysuria and hematuria. In areas where it's endemic, they say that about 50% of the kids will have red urine by the time they're 10 years old. It can also increase your risk of glomerulonephritis of many different types. The granulomas can eventually cause bladder fibrosis and obstruction, which predispose to bacteriuria. And the nitrates that are released by the bacteria over time can predispose to cancer. So if you look at this progression here, these are kind of the classic yellow plaques seen with schisto. And over time, it'll eventually develop into circle F, which you can see as a fungating mass. And it can cause transitional cell bladder cancer, as well as adenocarcinomas, seen here. And if you look at these red dots here, anywhere where you lay the eggs in the genital tract of a man or woman, you can imagine that the granulomas will form and cause problems. So they could cause prostatitis, infertility, increased risk of STIs, increased risk for ectopic pregnancies. And female genital schistosomiasis is something that's really under-recognized that I'd like to talk a little bit about. The WHO has this great booklet with pictures, first showing normal cervix, but also showing the cervicitis that can occur. So here you see yellow bumps from schisto. And you can imagine if you saw this when you were looking at doing a pelvic exam, you might think that the patient has cervical cancer. And that happens quite often, but I want to emphasize that hematobium causes bladder cancer. It does not cause cervical cancer. I'm going to say that again. Hematobium causes bladder cancer, not cervical cancer. And the reason why I'm saying this is hundreds, potentially thousands of women have had full hysterectomies with the thought of this being cervical cancer, when really they needed 1 day of praziquantel to help this infection heal. So you can also see on the cervix abnormal bleeding, pelvic pain that is a symptom that women often get, as well as dyspareunia. And here you see again these classic yellow plaques and increased vasculature here. So the next two species of schisto I'm going to group together, Mansoni and japonicum. And there are many more species, but I'm just going to focus on these three. So here you see the Mansoni egg. He has kind of a lateral spine, and this is a stool microscopy sample where you can see this egg. And I kind of always imagine that it looks like an egg pooping. So you're going to find this in your intestinal vasculature. And Mansoni is in South America, mainly Brazil, as well as sub-Saharan Africa and parts of the Middle East. Japonicum, which has kind of similar pathophys but different distribution, you're going to see here in China and the Philippines. I always remember it because it reminds me of the rising sun on the Japanese flag, but Japan actually eradicated this disease in the 70s, so it's no longer there. So let's talk about chronic Schistosoma mansoni and Japonicum. So we said they're going to lay their eggs in the liver and intestine. So here's our intestinal vasculature here. There's a bunch of little worm couples coupling up. And the symptoms that it causes, again, are because of the granulomas. So if you look here at all of these eggs, around them are a series of granulomas, and it's formed a polyp in the liver. You can also have bloody stools, weight loss, malnutrition, protein-losing enteropathies, appendicitis, any like GI symptom, kind of you name it. And then the chronic inflammation can lead to bowel wall ulceration, hyperplasia. And when eggs are laid in the portal vasculature, it causes a widening and a fibrosing of the portal vasculature. So here you see on a liver ultrasound, this is an example of what's called Stimmer's clay pipe stem fibrosis. I imagine when people used to know more about plumbing, this made sense. But you can see that, the plumbing here of the liver is a little bit dilated. And then in addition, with having portal hypertension, you're going to see gross ascites as well. I'd also like to talk for a moment about neuroschistosomiasis, which is a little bit more rare, but can occur with all three. Depending on the egg size, depends on where you see the problem. So here in the spine, the larger, longer eggs, so Mansoni and hematobium, can get caught in your spinal tract. And anywhere where eggs are, again, it's going to form granulomas, it's going to cause problems and neurologic deficits. The Japonicum eggs, which were the really small round ones, they can actually travel to the brain and cause neuroschisto in the brain. So let's talk about diagnosis for a minute. This is me attempting to do research. Don't worry, I was double checked by someone who knew what they were doing, a pathologist from Tanzania. But the gold standard would be direct microscopy of eggs and stool and urine. You want to collect 3 samples over 3 days between noon and 3. And our patient did actually need a sample at that time. It's important to know that this worm is maturing inside your body and then eventually growing up, making a family, and laying eggs. So you're going to have to wait 50 days after inoculation to get an accurate test and to actually shed these eggs. So if someone comes back from vacation, you can't test right away. It's not going to be accurate. On a UA in an area where it's endemic, hematuria would be schisto until proven otherwise. Antibody testing is also worth noting. So this detects the adult worm microsomal antigen. Again, because it's the adult worm, you need 6 or 8 weeks for that worm to grow up. And it can't distinguish between new or treated infections. So someone from an endemic area probably has a positive antibody, even if they've been treated. First step, you would do a fast ELISA. And then the second step is an immunoblot. And these are for the 3 different types. So microsomal, microsomal adult Mansoni antigen, hematobium, and Japonicum. So Mama, Hama, and Jama are the 3 tests you could get for follow-up. Other ways to test, you can have rectal and bladder pathology if you actually take SNP. Something that's kind of newer is the point of care circulating cathodic antigen test. This is kind of cool. So these worms have what's called a blind gut. So if you can imagine, the Mansoni worm lives in your portal vasculature, it eats your blood, excretes it by vomiting it up because it has a blind gut, just one entry, one exits. It vomits up that antigen, which is then excreted in your urine. So this is supposed to be a quick dipstick test for Mansoni. So that's the future. And PCR is really just used for research. Who are you going to test? You're going to test your asymptomatic patients from endemic areas. Many patients, 50%, won't even have eosinophilia, so you need to just test. You're going to test symptomatic patients with potential exposures. And then I put a question mark next to travelers with freshwater exposure in endemic areas. This is something to really counsel your patients on who are going abroad. There was a great study that showed 50% of people who went whitewater rafting on the Nile came back with schisto. So be aware. Let's talk about treatment for a moment. So praziquantel is your drug of choice. It kills adult worms. What it does is it increases calcium permeability in the worm. So calcium rushes into the worm and then causes seizures and muscle contractions. From there, a bunch of antibodies are released. And you really need an antibody response for this drug to work, because then your body is going to finish the job and kill off those adult worms. Which is kind of neat, because when you treat with praziquantel once, not only does it treat that infection, but it also increases your immunity to the next infection. So although people can be repeatedly infected, they do get a little bit of immunity over time. And again, because it only treats adults, you cannot treat until 4 to 6 weeks after the exposure at least. As far as treatment, it's just a one-day course, 40 to 60 mg per kg per day for kids and adults. And then just a warning is that it can cause seizures in patients with neurocysticercosis, so you want to get a good neurologic exam on your patients as well. Treating acute schisto, so if someone comes back with Katayama fever, is a little bit more challenging, because again, you're kind of in this teenager phase of schisto where praziquantel may not work. So you're going to treat that inflammatory reaction with steroids and then retest later. And there are some studies that show that other antiparasitics like oxamniquine and artemether work as well. The future of treatment is really in pediatrics. So this is important to us for us to know. There were actually phase 1, 2, and 3 clinical trials within the last 3 years that do show that treating kids that are greater than 6 months old is safe, which is great, because we showed that preschoolers have the highest infection rates. But part of the problem was not just that we didn't have safety data. The drug was a giant pill and it tasted gross. So this is probably the cutest RCT ever, where they did a blind swish and spit test of praziquantel in African children to make sure that they have a palatable option to treat that preschool age population. So let's talk about individual prevention, which I think is a lot easier said than done. You can tell someone not to wade or bathe in unsafe water, or not to drink unpurified water, but it's pretty difficult. Just of note, when you drink unpurified water, it's not that it's getting in through your gut, it's actually getting in through your mouth mucosa. So that's just one of the many ways you can become infected. And with prevention comes disease control. So it's all about neglected tropical disease control. And to do this, you really have to control the 3 different like hosts or areas that the parasite is living. So first you have your definitive host, us humans. You need to have freshwater avoidance, aka boiling water, water tanks, irrigation. Again, expensive and easier said than done. Then you have your intermediate host, the snails. You can prevent snail infection with things like latrines and better irrigation systems as well. You can also try to kill off the snails with molluscicides. And you can also practice better environmental practices as well. So one thing to note is that the damming of the Nile has actually led to a huge increase in schistosomiasis, because there's more shallow, hot water. And global warming is also thought to contribute to the spread and the prevalence of this disease. So it has a much bigger, everything is always more complicated than it seems. And then as far as the parasite, we need improved testing and treatment. Not being able to treat until 8 weeks later is not ideal. We need preventative chemotherapy and mass drug administration. I'm going to talk a little bit about what that is. So mass drug administration is kind of what it sounds like. Essentially, in endemic areas where you know that schisto has a really high prevalence, one of the ways that the countries and the WHO think that they can eradicate this disease is by assuming everybody has schistosomiasis and treating once, sometimes even twice a year. A lot of this is administered through schools, which is why preschool age is challenging, because most kids don't go to preschool in sub-Saharan Africa. But amongst school-age children at school, they will be treated for soil-transmitted helminths with albendazole and for schistosomiasis with praziquantel at least once a year. So like looking here, in in the DRC, you can see that less than 75% coverage of school-age children there. So, really not quite adequate in order to eventually achieve eradication. And multiple studies have shown that this is safe and that there's really no resistance to praziquantel. It actually increases your immunogenicity, which is pretty great. So let's circle back to our patient here now in Portland, Maine. So our patient was treated with praziquantel, 40 mg per kg per day, divided into 2 doses over the course of 1 day. And the plan was for a repeat UA and CBC in 3 months. So what are our take-home points here on our schistosomiasis patients? Going back to the objectives, I wanted you to learn about pre-departure chemotherapy. So again, this is the presumptive treatment of schistosomiasis with praziquantel for refugees from endemic regions. It's important to know that these things are so common that many immigrants are just getting treated for this. So if you have an asylum seeker who's not, you really want to think about the fact that they haven't been treated for it, and maybe they should have been. Who and when to test. So you're going to test all immigrants from endemic regions, even if they're asymptomatic on arrival to the US. You're going to test symptomatic patients, and sometimes you're going to test travelers 6 to 8 weeks after their exposure. And you're going to educate them not to go in fresh water that's known to have schisto. And last but not least, you're going to recognize the symptoms. So if there are 4 things I want you to remember, it's hematuria, portal hypertension, infertility, and bladder cancer. These are things that are easily recognizable and should trigger you to say, I went to that one random lecture on schistosomiasis once. So I realized that we went through a lot of things, and you don't have to know everything about schistosomiasis. I just want it to be in the back of your brain somewhere so you can know who's been treated for it, who you need to test and think about it in, and how to recognize it. Because you're going to see it more often. This is just our patient's journey from the DRC to Portland, Maine, but she is definitely not the last patient you will see. So that is my lecture. I'd like to thank a few people. So the first person I'd like to thank is my grandfather, who was wonderful in helping me prepare for this lecture and telling me all about Tanzania. I'd like to thank my husband, who heard me accidentally pronounce neglecticated about 7 times last night. Dr. Goddard and Dr. McCarthy from infectious disease, who gave me a lot of great feedback on my lecture. Drs. Powell, KDF, and Dr. Sears, you are all wonderful, and I appreciate you putting up with me throughout residency and pushing me to be a better resident, and also really supporting me anytime I wanted to learn about something unusual like this. All of the residents, you're fantastic, and I can't believe I've gone through half my residency during a pandemic with you. And then last but not least, my co-MedPeds residents. So Ariel and Erica are fantastic people. If I could share one ridiculous anecdote about them, it's that when my hedgehog was sick, they came over and they gave him subcutaneous fluids. So that's how good of friends and how good of doctors they are. And that is my presentation. Does anyone have any questions? Awkward silence. Okay, so I see some things in the chats. I muted. Good luck. Thank you very much. I have a patient who was previously treated, now undergoes yearly urine cytology to look for malignancy. Is that appropriate, and should it be lifelong? So I think that's a good question. My understanding is you can do repeated bladder ultrasounds. I'd have to actually ask Dr. McCarthy or Dr. Goddard about that question, and I can get back to you. I think it's also going to depend on how long you think your patient was infected for, what symptoms they had, and then if they had any abnormal initial cytology. But it's a great question. If anyone is able to pipe in, I'm not sure if you're allowed to talk, but if not, I'm definitely going to get back to you, Elliot. Colby Wyatt, how did the hedgehog do? He died, but he was a great hedgehog. He lived a long, wonderful life and had a week of hedgehog palliative care. Thank you for asking, Colby. Let's see. Salmonella. My hedgehog did not have salmonella. Dr. Olshan, how did you make those things where the car is in the planes slide across your slide? So I use this app called Picture Map. And then I took a screenshot video of it and then I uploaded it to YouTube to get it to do that. Thank you all very, very much. Any other questions? Elliot, I wish I could field your question. It's a great question, but I really want to know the answer. I don't think we have any definitive data, but I would like to know what the practice is. So Elliot says he thinks urology recommends the urine cytology. I think that makes sense. I mean, it is the most common cause of bladder cancer in the Middle East, so we should be thinking about it. Dr. DiGiovanni says, remember that the O&P will not pick up most cyst or strongyloides, which is very true. That's why in our clinic testing, we actually do the antibody testing. And although that's going to pick up a lot more than an active infection that's going to pick up an old infection, it's probably the best first sensitive screener. Is there a way to get more of our patients to do the stool samples? Oh man, this is a good question. I think having really close follow-up is probably one of the most important things. And this is really tricky, but I think asking parents too, if they know what time of the day their kids go and scheduling the appointment very soon after that can be helpful. So having really close follow-up every couple of days, I think is probably the best way. And follow-up in clinic, because just telling them to return it to lab, I feel like it just doesn't happen often enough. Also, with your question, Meredith, there was a study, or not a study, a QI project in the MedPeds clinic that I believe Kristen, one of our awesome PSRs, spearheaded, where we were calling all of our patients and giving them a reminder call to return our fit test cards. So just with a reminder call, we were actually able to increase our colon cancer screening by a huge percentage. I can't remember exactly how much, but you could think about just whenever you send out a stool sample, potentially starting a telephone counter, because it seemed to work with our colon cancer screening. And Dr. Goddard couldn't find any information on how often to screen for bladder cancer. Yeah.
Is there a reason why, given the good data that we have with retreating refugees for things, why we've not implemented just empiric treatment with albendazole and praziquantel in our asylum-seeking patients?
Yeah, good. So that's a good question. So Dr. Diamond Falk asked, given that we have presumptive treatments of refugees and we have good data to back it up, is there any reason why in our asylum-seeking patients we don't have presumptive treatment as part of our guidelines? Is there any data to back that up? And this is actually something that I looked at a little bit, but I couldn't find any data. And I think partially, I wonder if the lack of guidelines is because of the stigma against asylum seekers. Because even when you look at the CDC website, it doesn't really mention asylum very often, just that other immigrants, you can potentially do these things as well. So I do wonder if going ahead and treating would potentially be more efficacious and less costly, because you have to remember asylum seekers do not have insurance until they're granted asylum. So they're going to be paying out of pocket for all of these labs.
Is it possible to have infections be infected with schistosomiasis at different levels of maturity? And how do you approach a patient?
Yeah, so Chris asked if it's possible to be infected with schistosomiasis at different levels of maturity and how you handle that. And the answer would be yes. So for patients who live in endemic areas, and if they are frequently exposed to water, they probably will have both schistosomulae and adult schistosome worms, and they may or may not have also laid eggs already. So it's possible to have those three kind of age groups within one body. And remember, the only one that's going to be treated is the adult. As far as management, so it's important, again, if the person has been exposed within the last 8 weeks, you manage by retesting and potentially retreating 8 weeks later, which is why patients who live in endemic areas should frequently be tested and treated, even yearly or biannually. The other way to manage that would be if you are giving one dose of praziquantel, you have to remember that it's actually inducing your immune system against the adult worm. So that drug effect is potentially going to last several more weeks. And as some of the schistosomiasis mature into adult worms, that immunogenic effect is still working and your body's still going to be attacking those later developing adult worms, even though they didn't get that initial influx of calcium when the drug was given. Dr. DiGiovanni said the biggest issue is getting meds paid in time under free care, but labs are covered. That's great. And I imagine that changes healthcare system to healthcare system. Any other questions? Okay, thank you guys so much for coming. I really appreciate it. Thank you for having me as a Maine Med resident the last 4 years. I look forward to being a primary care doctor and representing Maine Med in my next stage.
Yeah,